So I wanted to start off by saying that doing this is a teamwork. There is no I in a team, as Colin Natali used to teach me when I was his registrar. It is a proper teamwork. We all are physicians or surgeons trying to treat a patient, and the one thing we don't want to do is give a negative message to a patient. So we work as a team to try and get this patient across for some symptom relief. 90% of back pain and neck pain do get better with conservative measures and early activity. There is no true role for bed rest. You know, patients, when they ask me, what can I do? I say, you do what you're comfortable doing. If it is aching, you can carry on. If it is a sharp pain, don't do that. So that's the simple advice I try and give patients. It's a quick sort of examination guide for, when you see a patient with a back pain, if the flexion is going to increase the pain, it is usually probably from the disc. If it is extension, it is probably from the facets. And you look for asymmetry of the shoulder and waist, which could be related to true deformity, or it could be related to a muscle spasm. And you look for whether the patient is very kyphotic or hyperlordotic, which again can lead to some problems. You look for muscle spasm in the back, and the patients who have a severe back pain will have a spasm, and which is a good indicator. And for neurology, we get 30 seconds in Royal London to examine a patient, and at that time, it is a very quick, easy of going on tiptoes, going on your heels. Can you stand on one leg? So that is from L3 to S1. You have assessed your myotomes. And similarly, in the upper limbs, you look for whether they can close and open the fist and reach for back of the head. That again gives them some C5 to T1. That's a quick assessment of neurology. Red flags, very quickly, is if the patient has a true bowel and bladder incontinence, you're going to refer them on to A&E. I'm not interested in urge incontinence or a stress incontinence, which is very common in multiparas or elderly patients. I'm interested in a true incontinence where they say they've gone, but they've not felt that they've gone. And that is for both for urine and for feces. And I wouldn't expect you to do a PR examination, but if you do, it is a question of checking the sensation in the perineal region, and also to look for anal wink, which is absent in most of the patients above 40, and you look for sensation when you put the finger in to the anal canal, and you ask them to bear down, feel the squeeze. These are the 4 things to check when you're doing the perirectal examination to rule out red flags. If a patient has associated leg or arm pain, we as surgeons can be of help at an earlier stage. Investigations, I wouldn't expect you in the primary care to do x-rays. I'll tell you why I do x-rays. An MRI scan has become almost like a gold standard, and in some circumstances, we do use other forms of scans, like high-resolution CT, which is available in independent. This is the disc when you're born, which is avascular. There are 2 structures which are avascular in the body. One is the lens in the eye, the disc, and the third one is the hyaline cartilage in the joints. As we get older, these becomes vascularized. There is something happening there. That's why you have cataract. That's why you have degeneration of the disc, and that's why you have arthritis. And this is the disc when we are 20s, when it starts forming fissures. And this is the disc, most of us in this room, and that is the disc in probably some of us in the room. And as Dean already alluded to, I'm not going to talk specific about analgesics or anything, but simple analgesics, non-steroidal anti-inflammatory, along with some form of muscle relaxant. And that's what I tend to give as a first step. And then we go on to second line, but I'm a bit reluctant to prescribe opioids as a secondary care physician for more than a small period of time, like a week or so. There is a role for spinal injections, definitely in helping them with the rehab, because rehab is the main part of treating the back and neck pain. And there are certain specific injection techniques which ourselves and pain specialists do, which help with these patients for recovery. I specifically put physical therapy because it includes chiropractic, osteopathic, and physiotherapy. Chiropractic is an American school of thought. Osteopathy is a British school of thought. But almost similarly, they do the same thing, which does form a good thing for treating these patients, complex group of patients. Exclude red flags, good advice, positive advice, good analgesic control, therapy, injections, surgery, which is in less than 10% of the patients that me and Colin see. Busy slide. What I want you to concentrate on, we try and keep our patient group here with a low risk, with non-surgical treatment, and higher the chain that we go, it is like a one-way road. I tell patients there is no reverse gear. We go up, and there are some high-intense treatment like fusions, but once we go there, there is no point of return for that particular segment. We try and now do things like stabilization and motion preservation. I'll talk to you about in a minute, but we will talk about fusion, and I'm sure Colin will be talking about more fusion. Spinal injections do work reasonably well in 60 to 70% of patients. I tell them it is not just the pain-relieving injections. If you say pain-relieving injections, some of the insurers are nowadays not giving authorization. It is a modality of treatment to help with the rehab. And this is one of the reasons why I do x-rays is this is what we call Bertolotti syndrome. It's the transverse process of the L5, which articulates with the pelvis. Until you do an x-ray or a specific sequence MRI scan, we don't appreciate it, and patients keep coming back with the unilateral pain in the back. And this is the same patient who had an MRI scan. If you do a standard MRI scan, which many of you do have access in health, they don't do these specific cuts, which show the edema in the coronal section, which is not done if you do a routine sequence MRI scans. I'm not saying one should do all these patients this sort of a scan, but it is to correlating the clinical history examination and then asking for the specific investigation. Low risk, repeatable, and I say it gives you a window period of opportunity for rehab. That's the main idea of injections. Radiofrequency is nothing but doing the same thing along with heating and killing some of the pain fibers arising from the joints. When you have facet injections which helped for few weeks to few months, and the patients keep coming back with the same problem, but they're not bad enough for surgery, sometimes we do this radiofrequency, which is quite effective, and it does tend to last for 6 to 9 months. They may come back in the primary care sometimes after an injection. They've had some headache. It could be related to a small CSF leak, and it is very unlikely to cause a big problem. I would suggest plenty of fluid intake, caffeine, etc. Or if the headache is quite persistent, codeine can be quite effective. As I said, we tend to cherry pick and choose and pick which are the patients who we want to offer surgery after failing conservative management. And again, in spinal surgery, Colin, when I was his registrar, he took me aside and he told me there is no word called cure. If you ever mention a word cure to the patient, you're not fit to become a spinal surgeon. So what I tell patients is it is helping you live with the symptoms. And unfortunately, there are 33 joints in the spine, unlike 2 hips, 2 knees. So we tend to do one joint at a time and deal with one or the other, and then as the pain goes up to the next level, then we deal with that. I'll try and concentrate on 2 areas: cervical radiculopathy, neck pain, and pain in between the shoulder blades. It is from the facets of the neck, and radicular pain, pain down the arm. In the primary care, I would expect a combination of analgesics with anti-inflammatories. Is there a role for soft collar? Not necessarily. There is no evidence that it helps. But for comfort, one can have a collar for just a couple of days, which may help for just a few days in the spasm. Similarly, in the lower back, people ask about, can I wear a lumbar belt? There is absolutely no evidence that it helps, but it gives you comfort, and many times it is not advisable to use these methods for a prolonged period of time because it weakens the muscle and you become a bit dependent on them. And again, we say physical therapy, which includes physio, osteo, and chiropractic treatment. So most of us in this room, with a bit of a pinch, with arthritis of the facet and the disc which is bulging out, and MRI scans sometimes get underreported if the musculoskeletal radiologists who we work regularly with, they do give a very good report because of the clinical picture that we give. And this is the nerve root on the left, and that's the nerve root on the right. And this was reported as very minimal impingement on the nerve root. But if you look at the picture, clinical picture, this patient was having rip-roaring arm pain. That nerve root is more than 50% compressed compared to the other side. Similarly, again, look at the size of the nerve there, and look at the size of the nerve there. It is more than 50% compressed. And again, these patients do have a significant neck and arm pain. Just because they have that doesn't equate to surgery. They go through the same thing of analgesic, advice, excluding problems, and treating them with conservative measures, if appropriate injections, physical therapy. When they've failed, they go for fusion, and this is fusion in the neck, and it is helpful to do these where there is some critical care support as well, in case if they need it. When you have a soft disc, it is just a prolapse, but the height of the disc is reasonably maintained, there may be a role for cervical disc replacement, but the take-home message for disc replacements is there may be a role for in the neck. There is absolutely no role for it in the lumbar spine. Our technology is not good enough yet. And in the neck, the only advantage is the return to function or hospital stay is probably a bit less with the disc replacement. Apart from that, one cannot say this is superior to fusion. It is all the companies which sort of try to push it by marketing, this is superior, etc. But in spinal surgery, the fusion is almost like a gold standard. And yes, patients read internet and they come and ask for it. Sometimes we do give in a well-selected patient with a soft disc. Indirect spinal decompression, we start with kyphosis, and then we become lordotic, and then we end up with kyphosis. I mean, it is a natural evolution, natural progression. And essentially, indirect decompression is nothing but putting a small wedge in between the spinous process to open up the space of the neural foramina. In a well-selected patient, this helps with leg pain. The surgical morbidity is very less, and the complications associated with this very less. But again, watch my words, it is for a well-selected small group of patients, not for all patients with spinal stenosis. Decompression is a standard modality of treatment. In primary care, I would like you to rule out a diabetes or peripheral neuropathy. If there is any associated vascular pathology or any vascular disorders, if there is any access for hydrotherapy, it is a very good modality of treatment for spinal stenosis. And physical therapy, again, can be helpful. And the reason I mention about refer early is about whether those can be suitable for the spaces. This is neural foramina when you're standing up. And as we get older, it gets a bit smaller, and with a spacer in the back, it opens up the space for the neural foramen. This is a typical MRI scan, which again shows this nerve root, which is like a key in the lock, and this key is a bit squashed by the impingement of the facets. And this is the axial MRI scan showing that there is no huge amount of central canal stenosis. That's the nerve sac, and that's the nerve to the left, that's the nerve to the right, which is being squashed by the facet joint. And these are the scans which are done lying down. So when you lie down, you almost obliterate a little bit of lordosis. So that's why I do dynamic X-rays. When I ask the patient to stand up and look for flexion extension, I wouldn't expect you to do it in primary care, but when we try to choose a patient for surgery, I want to know whether there is, number one, instability, number two, whether there is any impingement, dynamic impingement of the nerve root, like in this patient, where when he is standing back, this facet joint is impinging on the nerve root, and when you lean forward, that's why these patients typically lean onto trolleys when they go to supermarket. So the patient is done under general anesthetic. It takes 20 minutes to do this procedure, done in a very small incision, less than an inch, and the blood loss is extremely minimal, and we don't go near the nerves to cause any compromise for neural structures. This is one of the implants that we did, and again, when you do flexion extension, the neural foramina is patent. All the implants that we use now in spinal surgery are MR safe. You may have a patient who comes back and says, oh, should I do an MRI scan? This patient had a spinal surgery. All the MRI scanners now have metal suppression software, and also we have all moved to titanium, so it is MR safe and compatible. I don't want to bore you with the studies. We published it, and it showed that it had a reasonably good result at 2 years. But what one has to realize is spinal surgery, the results in 2 years and 10 years are not the same like in hip or knee surgery, 2 years and 10 years. It's different. I think I'll stop there because I'll get Colin to talk on size does matter, minimally invasive surgery.